It is now my pleasure to introduce Dr. Larry Sperling. Larry is the current Executive Director of the Million Hearts Initiative for the Division of Heart Disease and Stroke Prevention at the Centers for Disease Control and Prevention and the Center for Medicare and Medicaid Services. He is the founder and was the director of the Heart Disease Prevention Center at Emory since 1997. He is currently the Katz Professor in Preventive Cardiology at Emory University School of Medicine and Professor of Global Health in the Rollins School of Public Health. He served as the President of the American Society for Preventive Cardiology from 2014 to 2016. Served on the Writing Committee of the 2018 American College of Cardiology and the American Heart Association Guideline on the Management of Blood Cholesterol, and served as the chair of the World Heart Federation Writing Group on the Roadmap for Cardiovascular Disease Prevention among people living with diabetes. Dr. Sperling was the recipient of the 2017 Award of Honor from the Alumni Association of Emory University School of Medicine. He has received awards for excellence in teaching, including 4 Golden Apple Awards and the Dean's Teaching Award, Mentorship, Emory School of Medicine 2018 Mentorship Award, and the R. Wayne Alexander Research Mentor Award. He has authored over 350 manuscripts, abstracts, books, and has been an invited speaker on every continent except for Antarctica. And he is a fellow Emory alum. Dr. Sperling, over to you.
Thank you for the opportunity to speak at the 3rd Annual Rotary Symposium. I'll be speaking about the post-COVID future of cardiovascular disease prevention. I have no conflicts or specific disclosures related to my presentation today. Importantly, the opinions I'll be discussing reflect my opinions and not those of the organizations I work for, work with, or serve. Before we get to discussing the post-COVID future of cardiovascular disease prevention, I'd like to take you on a little tour through the past, emphasize our present reality, and then I'll finish up talking about the post-COVID future of cardiovascular disease prevention. So the past, I'm going to call BC, before COVID. And in the world of cardiovascular disease prevention, the father of cardiovascular prevention was Paul Dudley White. He was an advocate for heart disease prevention, an impetus behind the Framingham Heart Study, helped create the NHLBI, the American Heart Association. He was Eisenhower's physician following Eisenhower's heart attack. And Dr. White said, exercise more, eat healthy, learn your family's medical history. Well, another chapter of the past was Paul Dudley White's last fellow at the Massachusetts General Hospital. This was J. Willis Hurst, and Dr. Hurst was one of my mentors. He was chairman at Emory's Department of Medicine for 35 years. He was Lyndon Johnson's physician when Lyndon Johnson had his heart attack in 1972. And Dr. Hurst greatly encouraged me to start our Center for Heart Disease Prevention at Emory, which I founded in 1997. This coming October the 21st would have been Dr. Hurst's 100th birthday. In 1961, with 2 words, Dr. Bill Cannell helped to change our understanding of the underlying causes of heart disease and stroke. And with these 2 words, the field of preventive cardiology was born. These 2 words were risk factors. And we know well today what are called the traditional heart disease and stroke risk factors: high blood pressure, cholesterol abnormalities, smoking, diabetes, and so on. What was learned early on in Framingham was that if you had multiple cardiovascular risk factors present, your cardiovascular disease risk was exponentially increased. When the National Institutes of Health was launched back in 1940, by Franklin Delano Roosevelt. He said, "We cannot be a strong nation unless we are a healthy nation." And by the way, it is the National Institutes of Health and not the National Institutes of Disease. I've been fortunate to work with the World Heart Federation. These are quotes from two former presidents. Salim Youssef said, "Cardiovascular disease is the biggest epidemic, and really it's a pandemic, ever known to mankind. We need strategies to address epidemics." And Valentine Fuster said, "Secondary prevention is urgent." Well, looking at the photo on the left of this slide, except for it being in black and white and for the wide brim hats, you might guess that we're in the present as opposed to in the past. Individuals wearing masks, and then the sign on the right-hand side, a public notice, which is prohibiting public gatherings. This was 102 years ago during the Spanish influenza pandemic. And although the last 7 months have been quite a blur, our world certainly has changed since January of 2020. These photos I took when I was giving grand rounds at the University of San Diego in California. Well, that was a little bit about the past. We are very much immersed in our present. And our present right now is we live in a present COVID world. What we've seen is a bidirectional interaction between cardiovascular diseases, cardiovascular risk, and COVID-19. This is a figure from Nature Reviews Cardiology. Initially, COVID was thought to be primarily a respiratory virus, but early on, we saw a definitive cardiovascular expression or manifestations of COVID-related diseases, including acute heart-related injury, heart attacks, stunned hearts, hearts that were, we call it a broken heart syndrome, related to the interaction of a cytokine storm, and heart rhythm problems in addition, as well as direct myocarditis or inflammation of the heart, and an increased risk of clotting both in the arteries and the veins. What we also learned in terms of this bidirectional interaction has been that those living with serious health conditions, which includes heart disease or diabetes, have an increased risk of significant COVID-related disease. This paper, published back in late July, received a lot of attention and raised a lot of questions and concerns. This was a paper out of Frankfurt, Germany, looking at 100 individuals, a median of 71 days after their COVID infection. Many of these patients had not been hospitalized and were mildly ill. 70% or more of these individuals were found by cardiac MRI to have involvement of the heart, and there was evidence of low-level active inflammation of the heart, both by imaging and by biomarkers. And this appeared to be independent of pre-existing conditions or severity of the COVID-related illness. And several of the individuals who were sicker, biopsies of the heart were done, and there was evidence of significant inflammation of the heart muscle. Another paper published in Lancet looked at an autopsy of cardiac tissue from a child who had multisystem inflammatory syndrome, COVID-related, and also saw evidence of direct cardiac involvement of the virus. This was the headline in the New York Times late in April. Amid the coronavirus crisis, heart and stroke patients go missing. What we know now is that these patients were not missing, but where they were missing from were hospitals and emergency rooms. Very soon after the COVID pandemic began to affect Europe and Italy in specific, this paper was published in the European Heart Journal that showed a significant decline in presentations and admissions to the hospital for heart attacks in the range of about 50%. In the US as well, this is from an MMWR, in the 10 weeks following the COVID national emergency declaration, there was a 23% drop in presentations to US emergency rooms for heart attacks, 20% drop for stroke, and 10% related to uncontrolled high blood sugar. I mentioned the interaction between COVID-19 and those who are living with serious health conditions, and those with serious health conditions such as underlying heart disease, diabetes, or lung disease are at a 6 times greater rate of being hospitalized from COVID, a 5 times greater rate of being admitted to the ICU, and a 12 times greater rate of dying of COVID-related disease. This is from a recent MMWR, and this is something we really need to pay attention to, that the delay or avoidance of medical care is something that is really playing out right now all across the world and across our country. So an estimated 40% of US adults have delayed or avoided both urgent, emergent, and routine care, seen greater in those with multiple medical conditions. And this might contribute to the reported excess in deaths directly or indirectly related to COVID-19, but it does inform us that in healthcare and public health, we need to be communicating very appropriately about encouraging those with signs and symptoms of heart attacks or strokes to seek emergency care as soon as possible. There have been multiple waves, and these waves are not necessarily direct waves of COVID, but these waves or curves are happening related to health in our population, delivery of healthcare, and public health. And these waves are affecting urgent care, continuity of care, those living with chronic diseases, and certainly mental health, stress, anxiety, and depression. Earlier, I briefly touched upon the excess deaths that are occurring, and I think we fully do not appreciate the impact of the COVID pandemic on mortality. This slide depicts excess deaths in the US from March to May of 2020, the upper curve related to the dotted curve, which was a comparison a year ago. So for the patients we're caring for during the COVID-19 pandemic, we want to emphasize the importance of keeping up with their regular care. We have rolled rapidly into the use of telehealth and telemedicine. At each visit, we should be asking our patients not only about their symptoms, but encouraging them, if they do have acute symptoms, that our hospitals are safe and ready to take care of them. We want to ensure they have their regular medications available. Inquire about their activity and nutrition, stress and anxiety, and how this has been affecting their life and their family, and use the full care team. I learned early on through delivering telehealth and telemedicine that vital signs are more vital than ever before. For patients who do not have home blood pressure devices, being able to understand what's going on with them, if they're dizzy or they're having other symptoms, or how to adjust their medications, has been quite a challenge. And so we need to, as we think about the future, understand that we'll be delivering more care through telehealth, telemedicine, and community-based services. I do want to make mention right now, as we roll into the influenza season, that this will be the most important influenza season to have those living with serious health conditions such as heart disease, but the general population to have influenza vaccinations, not only to protect themselves, but to protect others. This is a class 1 recommendation for heart disease prevention, just like taking a cholesterol medicine or stopping smoking. We know that after influenza infection, there's a greater risk of heart attack and stroke and hospitalization for heart-related illness. Well, related to cardiovascular health, prevention, and cardiovascular care, all of these must remain a priority during the pandemic. This slide depicts what I call a concerning directional change in heart disease and stroke trends. Cardiovascular diseases have been the leading cause of mortality in our country since 1910, with the exception of the time of the flu pandemic in 1918 to 1920. Cardiovascular diseases really are related to the greatest racial and ethnic disparities in health and healthcare, and this has occurred now for decades as well. Over the past 10 years, though, we've seen a stagnation in these trends related to heart disease and stroke rates, and even now an uptick. This is from some of my colleagues at the Division for Heart Disease and Stroke Prevention at the CDC, Trends in Cardiovascular Medicine, an alarming mortality rate change, which is really a healthcare and public health crisis among younger adults. Increasing rates of heart disease and stroke mortality in 2/3 of the counties of the United States. There are truly millions of opportunities that are missed to prevent heart attacks and strokes. Not taking aspirin appropriately, uncontrolled high blood pressure, not using cholesterol medications, individuals who are still smoking and inactive physically, and over half of these are in the young adult population. We absolutely need to change the conversation related to heart disease and stroke prevention. And this slide demonstrates the disconnect between what we're dying from, heart disease here in blue, and what the conversation is about related to Google searches and Guardian database and the New York Times. And so we have become complacent and accepting that the #1 cause of death is heart disease, and stroke remains a leading cause of death in our country. The present is quite concerning as well, because obesity remains one of the health conditions associated with a poorer outcome related to COVID. This is from the New England Journal of Medicine last year, a paper that says that by 2030, half of all Americans will be, by definition, a BMI greater than 30 obese, and a quarter will be severely obese. I've shown this slide all over the world, and although we can determine today our genome or our genetic code, our zip code, where we live, is a more potent predictor of risk for risk of disease, but a general predictor of our health. And so in Buckhead, Atlanta, here north of the city, compared to Bankhead, which is less than a 15-mile drive, there's a 13-year difference in life expectancy. Some of our research at Emory, this is one of our recently former fellows, Haval Kelly, we've looked at food deserts or areas of food insecurity. A little less than 1 out of every 10 Americans live in food deserts. And this green map, the areas of green here around Atlanta, these are not parks. These are areas of food insecurity that are associated with early cardiovascular risk and more significant demonstrations of physiologic and anatomic cardiac abnormalities. On a global level, over the past several decades, what has happened is that ischemic heart disease has snuck up on us as the #1 cause of morbidity, mortality in what has now become a very global economy. In the US, unfortunately, 3% of Americans have ideal cardiovascular health, only 3%, and about 10% have poor cardiovascular health, with disparities by age, gender, education, and ethnicity. That is from a behavioral surveillance and risk factor survey of over 350,000 Americans. Well, now we've talked about the past. We're very much in the present. I want to finish my presentation focusing on the post-pandemic future and the post-COVID future of cardiovascular disease prevention. On a chat site, a Doc Matter chat site for the American Society for Preventive Cardiology, a trainee asked the question, what will be the future of preventive cardiology post-pandemic? And at the time of this query, March 22nd, you can see that there were only 508 deaths in the US related to COVID. Well, here we are today, March, boy, I mean, we're 6 months past that time, and now in the US, we're approaching 7 million COVID cases and over 200,000 deaths, and approaching the 1 million death milestone on a global level. Well, I answered this question, the future of preventive cardiology, and this led to several editorials, one published in Circulation. And in the editorial, I mentioned that I thought the risk for COVID-related morbidity was being driven by the interaction of a viral illness with an unwell population, and we need to invest more than ever in essential services like cardiovascular prevention, population health initiatives, and robust public health programs. And in the Cardiovascular Endocrinology and Metabolism journal, we published this commentary related to the importance of cardiovascular and cardiometabolic prevention being a high-level priority in the post-pandemic recovery, and that the lessons we learned during this pandemic will be critical to ensure the health of the population going forward. I've been using this quote very frequently, an Albert Einstein quote that says, "In the midst of difficulty lies opportunity." It is clear that the future of cardiovascular medicine, it has to be a greater focus on cardiovascular health and cardiovascular disease prevention. This is a paper we published now 5 years ago in Circulation, in JACC, and this is the health disease continuum, this figure. As a cardiologist, we frequently encounter disease at a late stage, and it's important that we better understand what it means to be healthy versus diseased, to better focus on health promotion and disease prevention. This paper we published in Circulation a few years ago, and as we look at the COVID-related illness, there's a spectrum of risk related to age, serious health conditions, but also related to social determinants of health. And we need to think very differently as we approach social determinants of health, access to care, healthy foods, psychosocial, behavioral, and environmental factors, as opposed to how we think about traditional cardiovascular risk factors. Our interventions need to be really focused in a different place as we think of social determinants of health. This is a paper we published a number of years ago, the Cardiometabolic Health Alliance, thinking about cardiometabolic risks. So in the US right now, 1 out of every 3 to maybe 4 adults, depends on the population, have cardiometabolic risk or prediabetes. We looked at this and we described this related to stages, and the stages that individuals are in are connected to how we think about a therapeutic approach, as well as how we should think about population and community approaches to care. On the clinical end, in terms of cardiovascular disease prevention, therapeutic inertia has been an obstacle or a barrier, and there's been inertia at the level of the clinician, at the level of patients, but at the level of teams and systems. Well, what is clear is the post-COVID future. We are in the midst of accelerating new care models such as telehealth and telemedicine. There hopefully will be a decreased use of ineffective and low-value care and a greater push from volume to a value transformation. As well, what will likely be occurring will be a rapid movement to further healthcare integration and consolidation. We do need comprehensive and complementary prevention programs focusing on where we're born, we live, we work, we learn, and we play. So this is connecting the dots between traditional healthcare, public health, industry, workplace, our schools, our churches, our communities, our environments, and our government. I've seen some success stories around the country, so this can be done. Success stories in San Diego, Nashville, Northern California, South Carolina, and Minnesota. I've had the opportunity to work with the World Heart Federation over the last several years, and the World Heart Federation is partnering with the International Diabetes Federation to fight cardiovascular disease and diabetes. I chaired the roadmap for cardiovascular disease prevention among people living with diabetes, and when we could travel and travel internationally, We presented this work at the European Society of Cardiology meeting last year in Paris. And this roadmap is a focus on those living with diabetes, but importantly, there is an emphasis on implementation science. The roadmap is for those living with diabetes, but also an integrated approach, connecting healthcare systems, public health, and health policy. So will the future be precision medicine, or will it be population health approaches? Precision medicine is providing the right treatment to the right patient at the right time, but precision public health is providing the right intervention to the right population at the right time. Since October of 2019, I've been serving as the executive director of the US Million Hearts Initiative. This is a co-led initiative between the CDC and the Center for Medicaid and Medicare Services. This initiative is focused on preventing 1 million heart attacks, strokes, and cardiovascular events in the United States by keeping people healthy, optimizing care, and focusing on priority populations. We know keeping people healthy is really at a population level, reducing sodium intake, decreasing tobacco use, and increasing physical inactivity, optimizing care, especially in those with heart disease and who are at higher risk, and certainly looking at those who are priority populations related to the future and the opportunities to prevent 1 million events. 1 million hearts, along with antibiotic resistance, HIV elimination, opioid overdose, vaccine preventable disease, and viral hepatitis is considered one of the CDC's winnable battles. A winnable battle is a public health priority where the CDC and its partners can make a significant progress in a short period of time. So what should our post-COVID future for cardiovascular disease prevention look like? Well, this is a great paper published looking at the 3 buckets of prevention. The first bucket being traditional clinical prevention. The third bucket, community-wide prevention or population health approaches. The second bucket being innovation and innovative clinical prevention, connecting the clinical world and the public health world at the level of the community. Well, we are very much in the midst of a global pandemic right now, but cardiovascular diseases and cardiometabolic diseases are epidemics and pandemics, and we need to think similarly as we would related to an infectious disease pandemic by identifying the vectors and complex causes, identifying barriers, roadblocks, and factors that propagate these pandemics, focusing on the goal of control, elimination, and hopefully someday eradication. So to conclude, the post-COVID future of cardiovascular disease prevention, we know right now in the present that COVID impacts the cardiovascular system, is impacting cardiovascular care and cardiovascular outcomes. Cardiovascular health and prevention need to remain a priority in the midst of this pandemic. And in the future, there's a greater need for the integration of healthcare and public health at the level of the community. I'll conclude with these 2 quotes regarding the future. The first is a Yogi Berra quote, the former catcher of the New York Yankees. Yogi Berra said, "It's tough to make predictions, especially about the future." And then the second quote from William Shakespeare, "It is not in the stars to hold our destiny, but in ourselves." I thank you for your time and attention today, and I look forward to your comments and questions. Thank you again to the program organizers for providing me the opportunity to speak today during the symposium.